Welcome back to Veterinary Epidemiology. Really happy for you to be here today. Today's module introduces the core concepts behind experimental study designs with a focus on randomized controlled trials, the strongest design we have for establishing causality. We'll walk through the essential components of RCTs, including randomization, blinding, intention to treat analysis, cluster trials, and crossover designs. These are the building blocks of high-quality intervention research in veterinary medicine. Throughout the module, I'll connect each concept to real veterinary examples, vaccines, mastitis treatments, metaphylaxis programs, and highlight the practical challenges that make veterinary RCTs unique. By the end, you should feel confident interpreting RCTs and understanding how design choices influence internal validity. Let's get started. It shows where RCTs sit in the evidence hierarchy. Systematic reviews and meta-analyses of RCTs are at the top because they synthesize multiple high-quality trials. Individual RCTs come next because randomization uniquely balances both measured and unmeasured confounders, something observational studies can never fully achieve. As you move down the hierarchy, quasi-experimental, cohort, case control, cross-sectional, the risk of bias increases. These designs are still valuable, especially in veterinary settings where RCTs may be impractical, but they cannot match the internal validity of a well-designed randomized trial. RCTs rank highest because randomization distributes confounders evenly between groups, including variables we didn't measure or didn't know about. Blinding further protects against performance and detection bias, especially for subjective outcomes like lameness or pain scoring. Concurrent controls ensure both groups experience the same calendar time, eliminating secular trends. But RCTs also have limitations in veterinary medicine. They're expensive, logistically challenging, often underpowered, and sometimes ethically constrained. So while RCTs are the gold standard, observational studies still play an important complementary role. Randomization is the foundation of experimental design. It ensures each animal has a known probability of receiving each treatment, which creates comparable groups at baseline. We'll look at several types of randomization: simple, block, stratified, and cluster, each suited to different scenarios. We'll also classify allocation concealment, which prevents selection bias at enrollment. It's distinct from blinding, which protects outcome assessment after assignment. Understanding these distinctions is essential for evaluating the internal validity of any RCT. Simple randomization is essentially a coin flip for each animal. It's easy to implement and works well in large trials where group sizes naturally balance out. But in smaller veterinary trials, simple randomization can lead to uneven group sizes. For example, 31 versus 19 calves, which reduces statistical power. Simple randomization also doesn't guarantee balance over time if animals are enrolled sequentially. Despite these limitations, it remains a valid method when sample sizes are large or when imbalance is not a major concern. Block randomization ensures balanced group sizes throughout enrollment. Animals are randomized in fixed size blocks, for example, 2 treatment and 2 control animals in each block of 4. This prevents severe imbalance, especially if enrollment is staggered or the trial ends early. Block size should be concealed to prevent predictability. This method is especially useful in small veterinary trials where simple randomization may produce uneven groups. Stratified randomization ensures balance on key prognostic factors, variables that strongly influence the outcome. For example, if disease risk differs by farm or breed, animals are stratified first, then randomized within each stratum. This prevents imbalance on important variables, but stratifying on too many factors can become unwieldy. In practice, we stratify only on the most influential variables. Cluster randomization assigns groups, not individuals, to treatment. This is essential when the intervention operates at the herd or pen level, or when individual randomization would cause contamination. Examples include herd-level vaccination or pen-level feeding strategies. Cluster trials require special analysis because animals within a cluster are correlated. This reduces the effective sample size and increases the required number of clusters. Allocation concealment prevents selection bias at enrollment by ensuring the person enrolling animals cannot predict or manipulate the next assignment. This is different from blinding. Concealment protects the randomization process before assignment. Blinding protects outcome assessment after assignment. Proper methods include opaque, sealed envelopes or centralized randomization systems. Predictable methods like alternating animals or odd, even ID numbers are not true randomization. Protects against information bias by preventing owners, veterinarians, assessors, or analysts from knowing which treatment an animal received. Open label trials are vulnerable to both performance and detection bias. Single blind trials usually blind the assessor. Double blind trials blind both owner and assessor. Triple blind trials extend blinding to the statistician. Even partial blinding, such as blinding the lab or outcome assessor, meaningfully improves internal validity. Blinding matters because humans, not animals, introduce bias. Owners and veterinarians may unconsciously interpret outcomes differently if they know which treatment was given. This is especially true for subjective outcomes like lameness, pain, or appetite. Even though animals don't experience a true placebo effect, owners and assessors do. Blinding the outcome assessor is one of the most effective ways to reduce differential measurement error. Some veterinary interventions are impossible to blind. For example, surgery versus medical therapy or pasture versus confinement management. In these cases, we rely on alternative strategies, using objective outcomes, applying standardized scoring systems, or having independent blinded assessors evaluate the animals. We can also blind laboratory personnel who analyze samples, even if farm staff cannot be blinded. The goal is always to minimize differential measurement error. Placebo controls test whether a treatment works at all. This is an efficacy question. Active controls compare to real treatments. This is an effectiveness question. Non-inferiority trials are a special type of active controlled trial, where the goal is to show that a new treatment is not unacceptably worse than the standard within a pre-specified margin. In veterinary medicine, placebo controls may raise ethical concerns if an effective treatment already exists. Active control and non-inferiority designs are often more appropriate in those situations. To treat or ITT analysis includes all animals in the groups to which they were originally assigned, regardless of compliance or dropout. ITT preserves randomization and reflects real-world effectiveness. It's the preferred primary analysis for RCTs. Per protocol, or PP analysis, includes only animals that completed treatment exactly as planned. PP can overestimate efficacy because dropouts are often sicker or less responsive. PP is useful as a secondary analysis, but ITT should always be the primary approach. Trials are used when the intervention is applied at the group level, such as herd vaccination, pen level feeding strategies, or farm level biosecurity programs. Randomizing individuals would contaminate the control group or be ethically impossible. Cluster trials reflect real world implementation but require special statistical handling because animals within a cluster are correlated. The intra-class correlation coefficient, or ICC, measures how similar animals within the same cluster are. Even small ICC values like 0.01 to zero point 0.1 can significantly affect sample size requirements. ICC reflects shared environment, management, genetics, and pathogen exposure. Ignoring ICC leads to underestimated standard errors and inflated significance, a major source of false positives. The design effect, DEFF, tells you how much to inflate your sample size because of clustering. The formula is DEFF equals 1 plus M minus 1 times ICC, where M is the average cluster size. Cluster trials often require dramatically larger sample sizes, sometimes 5 to 10 times more, than individual level RCTs. Reporting DEFF is essential for transparency in sample size calculations. Cluster trials must account for clustering in the analysis. Acceptable methods include mixed models with random effects for cluster, generalized estimating equations, or GEE, or cluster level summaries. These methods adjust standard errors to reflect within cluster correlation. Failing to account for clustering produces artificially small p-values and inflated significance, a critical error in trial interpretation. Over trials, each animal receives both treatments in different periods, separated by a washout. This design is efficient and controls for between animal variability because each animal serves as its own control. However, crossover trials only work for chronic stable conditions. They are inappropriate for acute diseases, irreversible outcomes, or infections that confer immunity. Carryover effects must be minimized with an adequate washout period. A factorial design tests two interventions simultaneously. A 2 by 2 factorial yields four groups and allows estimation of each main effect plus any interaction between the interventions. Factorial trials are efficient, essentially two trials in one, but require careful interpretation if interactions are present. Size calculations require four parameters: alpha, or type 1 error, power, 1 minus beta, effect size, MCID, and baseline rate. Defining the minimum clinically important difference, or MCID, is essential. We don't want to power a study to detect trivial effects. Post hoc power analysis is invalid. Instead, interpret confidence intervals around the effect estimate to assess precision and clinical relevance. CONSORT flow diagram provides transparency about enrollment, allocation, follow-up, and analysis. It allows reviewers to assess attrition bias, protocol deviations, and whether ITT was properly applied. A complete CONSORT diagram is a hallmark of high-quality RCT reporting. Clinical trials treat existing disease. Field trials prevent disease in healthy animals. Community trials intervene at the herd or farm level. The choice depends on the research question: efficacy versus effectiveness, individual versus group level intervention. Understanding these distinctions help match the study design to the biological and operational realities of veterinary practice. CONSORT risk of bias domains: sequence generation, allocation concealment, performance bias, attrition bias, and detection bias. Each domain represents a specific threat to internal validity. A trial with high risk in any domain requires cautious interpretation. Low risk across all domains indicates strong internal validity. Outcomes can be binary, risk ratio, count, incidence rate ratio, survival, hazard ratio, or continuous, mean difference. Vaccine efficacy is calculated as 1 minus the risk ratio. Number needed to treat, NNT, is 1 divided by the absolute risk reduction. Always report confidence intervals. They convey precision and help determine whether the effect is clinically meaningful. We covered the essential components of experimental study design in veterinary epidemiology. RCTs are the gold standard because randomization controls both measured and unmeasured confounders. Blinding and allocation concealment protect against bias. ITT is the preferred primary analysis. Cluster trials require ICC and design effect adjustments. Vaccine efficacy and NNT help translate results into meaningful clinical metrics. Together, these concepts form the foundation for designing, interpreting, and critically appraising intervention studies in veterinary medicine. If you found this video helpful, please like and subscribe. Thanks, and I'll see you next time.